So you've had an anterior cruciate ligament injury and you're wondering, what do I do next? Well, first of all, you need to see a specialist to confirm the injury. They should take a good history of what's happened to you and you as a person. They should examine your knee fully for a combination of tenderness, swelling, and looseness in the knee joint itself. And then they will most likely request an MRI scan to confirm the diagnosis. If the diagnosis comes back as a complete anterior cruciate ligament rupture, then you have some choices to make. There are three main choices. The first is always manage it conservatively with physiotherapy and see if the muscles compensate. The second is see what happens. If physiotherapy helps stabilize the knee and you feel fine, then don't have a reconstruction operation. Or if you still feel unstable with the knee, then do have a reconstruction operation. And the third option is have an early reconstruction operation. There are many, many factors that go into deciding which is the best for you, and there is no one size fits all. The science is quite complex and at times conflicting. So I'm going to try and simplify the three main factors that I consider when I'm thinking about a patient who's had an anterior cruciate ligament rupture. The first is, what's the person like themselves? How good is their health? What are the risks of managing this with surgery compared with conservatively? The second is, what does the person demand of their knee? What would they like to use their knee for? And the third is, what is the characteristic of the anterior cruciate ligament in this person, and is it associated with other injuries? So the first is, what's the person like? Age comes into it. In general, younger patients, particularly below the age of 25, we find that they have higher demands on their knee, and if their cruciate ligament is not reconstructed, they can have recurrent episodes of an unstable knee that can lead to a meniscus tear. Between 25 and 45, there is a choice, but again, there is a tendency for the knee to remain unstable, and ligament reconstruction can be considered. Over the age of 50, although a lot of patients don't demand much of their knees, even in the over 50s, if the demands are high in the knee and the knee remains unstable, there is no reason not to consider a reconstruction. The second is the general health of the person. So there are risk factors that put up the risks of an operation. For example, body mass index of 30 or 35 will put up the risks of an operation with regards to blood clots, infection, and also puts up the risk of the graft not taking or not surviving once they go back to sport. So we've talked about the person themselves. The second is, what does the person demand of their knee? So if you're the type of person who is not really interested in returning to pivot sports or twisting or landing heavily, and perhaps only wants to cycle or run in straight lines, your knee can survive quite well without an anterior cruciate ligament. However, if you are into high impact pivot sports such as soccer or rugby or tennis or skiing, it is more likely that you'll put stress on the knee and less likely that the muscles will compensate, and in those cases, a cruciate ligament reconstruction could be considered. The third is, what does the cruciate ligament look like on an MRI scan? Is it completely torn? Is it partially torn? And even more importantly, what are the other structures that are injured? So often with cruciate ligament injuries, there can be a tear of the cartilage or the meniscus. Now those tears can heal, but they're more likely to heal with a stable knee. And you're more likely to get a stable knee if you have a cruciate ligament reconstruction, although your muscles may again compensate. If other ligaments are involved, for example, the posterior cruciate ligament or the lateral collateral ligament, and those ligaments are not healing well, then the more ligaments that are not working, the less stable the knee is likely to be and higher the likelihood of needing a cruciate ligament reconstruction. So I hope I've illustrated that actually the factors are quite complex. And the final factor, which could in fact be the most important one, is what you feel as a patient. What is your mindset? If your mindset is to avoid operation at all costs and to try conservative methods, that's perfectly reasonable as long as you understand the risks of that, which in particular could be a higher risk of meniscus tear. If your mindset is that you want to have the highest chance of a stable knee and you're willing to undergo the operation, which does involve some risks, then you may want to consider an early ACL reconstruction.